Good morning, everyone, and thanks for tuning in to Pediatric Grand Rounds this morning. As a reminder to everyone, the CME code is in the bottom right of the screen, and it is 130417. Our three speakers today are Dr. Kevin Havlin, Dr. Catherine Schuster, and Emily McCrae. Dr. Kevin Havlin is from Cincinnati, Ohio, and after graduating with a Bachelor of Science from Xavier University, Dr. Havlin studied neuroscience and physiology at Wright State University. He received his medical degree also at Wright State University Boonshoft School of Medicine. Upon completion of his residency at the University of Louisville Norton Children's Hospital, Dr. Havlin was elected Richard S. Wolf Chief Resident and Lecturer before completing a Pediatric Critical Care Fellowship here at the University of Louisville. He is currently on faculty with the Division of Pediatric Critical Care Medicine, where he splits his clinical time between the CICU and the PICU. Dr. Schuster attended the University of Cincinnati for medical school and completed physical medicine and rehab residency here in Louisville through the university in conjunction with Frazier Rehab Institute. Following residency, Dr. Schuster relocated to Houston, Texas for Pediatric Rehab Medicine Fellowship at Texas Children's Hospital with Baylor College of Medicine. Upon completion of this training, she returned to Louisville and has joined faculty in the Department of Neurosurgery, Division of Physical Medicine and Rehabilitation. She has recently become the Residency Program Director for Physical Medicine and Rehabilitation, which complements her interest in resident education. Clinically, her primary interest is with ongoing treatment of spasticity and traumatic brain injury. However, significant need for all pediatric rehab within the state of Kentucky ensures that she's involved in care needs for many different diagnoses across the spectrum of medical care. In addition to providing comprehensive rehabilitation care, she has partnered with the neurology department to create CAMP at Frazier, which is a program that addresses pediatric functional movement disorders, as well as continuing working closely with the heart failure and transplant team to address frailty within pediatric heart failure and transplant patients. More recently, she's found an interest in long-term management of acute flaccid myelitis and acquired spinal cord injury patients in collaboration with pediatric pulmonology. Emily McCrae is a certified pediatric nurse practitioner licensed in both acute and primary care. Emily's educational background includes a BSN from Virginia Commonwealth University, an MSN and postgraduate certificate from the University of Kentucky, and most recently her doctorate in nursing practice from the University of Louisville. Emily holds a dual faculty appointment in the Schools of Medicine and Nursing at the University of Louisville, and clinically she has practiced as an acute care nurse practitioner for 13 years at Norton Children's Hospital in the Pediatric Intensive Care Unit. Within Norton Children's Hospital, Emily remains engaged as a leader serving as chair of the Pediatric Advanced Practice Provider Council, a member of the Children's Hospital Medical Executive Committee, and most recently as a member of the Norton Healthcare System Safety Council. She enjoys advocacy work locally as a member of the Kentucky chapter of the National Association of Pediatric Nurse Practitioners, the Kentucky Organization of Nurse Leaders, as well as the Kentucky Association of Nurse Practitioners and Nurse Midwives. Emily has valued scholarly work, professional development, and networking at the national level throughout her career. She has remained active in the Society of Critical Care Medicine, where she currently serves as a member of the Online Module Committee and as a member of the Pediatric APRN Subcommittee. Additionally, she is a member of the National Association of Pediatric Nurse Practitioners and is currently serving as co-chair on the Professional Issues Committee. So we've got clearly three powerhouses here about to give us this talk, and I'm going to hand things over to them now.
All right, well, thank you, Julia, for those introductions. I'm going to go ahead and share our screen here. Give me 1 second. All right. Okay, well, welcome everybody, and thank you for joining us today. I'd like to start by thanking the members of this collaborative team, Dr. Kevin Havlin and Dr. Catherine Schuster, both of whom I have the pleasure of working with regularly. We are thrilled to be with you all today to discuss this diagnosis that offers pertinent information, across many of our fields, as this is a diagnosis that we often see in our population of chronically ill children. We're just as excited for the opportunity to be able to showcase this example of interprofessional collaboration. Our objectives are listed here on the screen for everyone to see. And while you look at those, I'd like to offer a little background related to this collaboration. So why discuss paroxysmal sympathetic hyperactivity? And from this point on, I and the rest of the team will be referring to this as PSH, so we don't continue to get tongue-tied. So during one of our monthly PICU APP education sessions, we reviewed an article that was published just last year in Frontiers in Neurology. This was intriguing and pertinent because we had several patients around that time in the PICU for an extended period of time following traumatic brain injury. The goal of the article was to present current and comprehensive studies looking at PSH after traumatic brain injury, specifically in the early stages, and then provide a framework for symptomatic management. This led to some rich discussion around our current practice in the PICU regarding the specific patient population. It was our collective perception that we have a variety of practice approaches and that management of PSH seemed to complicate the admission and likely increase the patient's length of stay. As it turns out, others share the same opinion. So after a brief literature search, I came across an article in Pediatric Critical Care Medicine from 2019 written by Dr. Mark Wainwright, who's with neurology at Seattle Children's. Wainwright made several key points in this article, but points out specifically that the study of PSH treatment exemplifies how lack of consensus of definitions can stall the advancement in studies and treatments of morbidities and critical illness in children. As you will see, we talk more about this, over time, not much has changed with regard to management of patients with PSH. So I just want to pause and say that lack of consensus around definitions is not unique only to this problem. However, I think it's important that we all take the time to step back and look at the big picture and be aware of any current or revised guidelines or lack thereof, and be aware of how this guides our daily practice in our respective fields and how it impacts outcomes for our patients. So I'll be discussing the background, definition of PSH, pathophysiologic theories that exist, present a scoring tool, and the proposed algorithm for management. Looking at the background of the problem, you can see several bullet points here on the screen. Back in the 1950s, there was a report of a constellation of episodic sympathetic hyperactivity that was noted following brain injury. So the identified symptoms you see here were transient fever, tachycardia, hypertension, tachypnea, excessive diaphoresis, and posturing. Despite trying to describe this disorder, it has been very challenging to understand the true prevalence because there can be diagnostic confusion, first of all, and then come to find out that in the literature, there are many different terms that we use to label this constellation of symptoms. A prime example of diagnostic confusion can occur actually in the same patient population. So patients admitted to the pediatric ICU following traumatic brain injury are often intubated and sedated for airway protection and to allow brain rest in the first 72 hours after the injury or the peak swelling. When we begin to lighten sedation, we try to monitor closely for signs and symptoms of withdrawal from sedation medications, which, by the way, often presents as low-grade fever that is also transient, tachycardia, and diaphoresis. So you get the picture. Then, as you can see on the screen, there have been multiple terms developed to label this constellation of symptoms. Some of you may be still wondering what PSH actually is, but I would venture to say that most of you have heard of this referred to as dysautonomia or neurologic storms. At least that was always what I referred to this condition as. So this is a major problem because it makes it challenging to even look up information. Again, lack of consensus of terms is problematic. Having said all of this, the literature tells us that the lack of early identification and standardized treatment leads to prolonged respiratory support, delayed neurologic rehabilitation, which then leads to increased hospital length of stay and poor prognosis for these patients. As it stands, PSH is a diagnosis of exclusion. And you can see on the screen, there's a variety of definitions listed, but most all of them outline the constellation of symptoms. Again, PSH is not fully understood. Interestingly, this was actually early on thought to be a form of seizure activity. More recently, there are two predominant theories, and those include the disconnection theory and then the second one being the excitatory inhibitory ratio model, or EIR model. So let's look at the disconnection theory first. On the left-hand side of the screen, you see a diagram of the normal connection of cortical inhibitory centers to the sympathetic control center. Within this theory, so moving over to the right-hand side of the screen, there's thought to be a disconnection of the cortical inhibitory centers to the sympathetic control center, leading to this constellation of symptoms. Alternatively, when considering the EIR model, on the left-hand side of the diagram, you see normal brainstem with normal sympathetic activity. So there is normal feedback of stimuli and descending inhibition. And there is a balance between inhibitory and excitatory interneuron activity. On the other hand, or on the right-hand side of the screen with PSH, in this model, it's thought that there is a disconnection shown as the broken line of descending inhibition, which in turn produces excitation of the feedback loop. Therefore, in these patients, non-noxious stimuli is perceived as noxious stimuli, thus leading to the constellation of symptoms. So in this article that we were originally discussing, the authors proposed a framework or algorithm for treatment based on a scoring tool that was developed. This scoring tool is referred to as the PSH-AM tool. So in 2014, and note the date, 1950s to our most recent update in 2014, the PSH assessment measure, or PSH-AM tool, was developed. This was created by an expert consensus group to outline probable diagnosis of PSH. So basically attempting to bring clarity to this picture. Looking at this a little bit closer, and hopefully you can see the screen. I know this may be a little bit blurry, but the scoring tool looks at clinical features and the patient receives points based on these features. A pediatric PSH scoring reference was also developed to include more age-specific ranges and vital sign norms, and you can see that variation here on the screen. Then the group outlined a DLT, or diagnostic likelihood tool. So each item on this list, if present, receives a score of 1, and if not present, the score would be 0. Therefore, on the DLT tool, patients can receive a total score between 0 and 11. In putting this all together, the PSH-AM score is the sum of the clinical feature score, peds or adult, and the diagnosis likelihood score, or the DLT score. So as you can see on the screen, once the PSH-AM score is generated, this score is grouped into categories based on the points to determine the diagnostic likelihood of PSH. And you can see that really down here by the PSH-AM score. So a score of less than 8 points means it's unlikely that the patient meets the criteria warranting a diagnosis of PSH. Patients with scores 8 to 16 are categorized as possible, meaning PSH is a possible diagnosis. And patients with a score of greater than or equal to 17 equals probable, meaning PSH is a probable diagnosis in this group. And so once the score, I know this algorithm is really small, but hopefully you can get the idea of what they're trying to do here. But once the score is categorized, it's determined, once the score and category is determined, the provider would reference this proposed management algorithm that you can see on the screen to determine a treatment pathway. And you can see that the treatment pathways include pharmacologic and non-pharmacologic options. This algorithm may not fit the needs for all of our patients. However, it's important, in our opinion, to know that this tool exists to at least help guide conversation and care, and to help the provider anticipate next steps in collaboration with other services to hopefully, in turn, streamline care, improve patient outcomes, and decrease hospital length of stay. So at this time, I'm going to hand the microphone or screen control over to Dr. Kevin Havlin, and he's going to talk about some case studies.
Thanks, Emily. So both of the patients that we're going to talk about right now are patients that are both dependent on mechanical ventilation, so they have not actually been on the wards at Norton Children's, but these patients also, don't necessarily have to be dependent on mechanical ventilation, and so this is kind of a relevant talk to those of you that work on the general wards, and especially those who work in the outpatient world, because ultimately all of these patients will go home at some point. And so the two cases we're going to talk about actually get into kind of the differences in how these patients can be managed, one of whom the management of PSH was initiated at Norton Children's, and one of whom their initial PSH management was initiated at a different children's hospital before they came to us. So this first case, this was a young boy who had an ATV accident. He had a 20-minute submersion in water with return of circulation after about 35 to 40 minutes of resuscitation. Fairly early in his course, had pretty severe hypertension, as you can see there, 160s over 100s. He had some agonal respirations and fixed and dilated pupils. An MRI obtained early in his course with us showed diffuse severe subacute anoxic brain injury to most of the structures of the brain, both hemispheres, the cerebellum and the deep gray structures, as well as moderate edema with minimal herniation. Within days of his injury, we began to document that he was having autonomic dysfunction, which is another one of the terms that is used to describe the constellation of symptoms that is PSH. And at that point, he was started on clonidine. He also had some, his constellation of symptoms was mostly heart rate and blood pressure lability, as well as temperature instability. About 2 weeks after his injury, we had consulted the PM&R team, who also recommended, in addition to the clonidine, to add propranolol, and Dr. Schuster will get into more of kind of the medications and how they help later on in this talk. And when this patient was discharged home, he was discharged home on baclofen, clonidine, and diazepam, as well as some weaning Neurontin. And then as an update, most recently, he was seen outpatient, I think looked like it was September, where his current medication regimen is baclofen 20 milligrams 3 times a day, which is max dosing. They did try to wean because the parents felt like it wasn't helping as much. There was a discussion about an intrathecal baclofen pump that we will talk more about with the next case, but the family was not interested. He is on 2 clonidine patches per week. His Neurontin dose has been increased, and this family is actually pursuing some alternative treatments that I don't think Catherine will talk too much about. But there are lots of kind of alternative treatments out there for patients with anoxic brain injury and traumatic brain injury, much of which the literature is kind of cloudy on. So they are pursuing hyperbaric therapy, stem cell therapy, as well as they're seeing functional neurology and pursuing laser therapy. Most recently, he has been weaned off of his Valium. They've started weaning his gabapentin again. This just as of, I think, September. And his storming has somewhat improved after being switched to the ketogenic diet. On an exam on his last visit, he is described as being mostly asleep. He has increased tone throughout, does have some reaction to pain, but still has lots of dystonic movements with stimulation. And then there is a mention, he also receives Botox per Dr. Schuster. And his last visit for the Botox, his mother had reported that she had seen some increases in his PSH symptoms after pursuing his initial stem cell therapy. This next case is a case that actually started at a different children's hospital and was transferred to Louisville when they were discharged to Home of the Innocents. So this is a young lady who had a car accident where she suffered a severe traumatic brain injury and spinal cord injury with resultant spastic quadriparesis. That was in June of 2019. She developed severe refractory spasticity as well as dysautonomia. And when she initially came to Norton Children's for the first time in January, she had been on amantadine, max dosing of enteral baclofen, diazepam, gabapentin, bromocriptine, dantrolene, propranolol, clonidine, and melatonin. So quite the cocktail of medications, kind of giving an example of how varied the management of these patients can be and how wide the medication use can be. She had multiple admissions with us for respiratory failure initially, and an intrathecal baclofen pump had been discussed many times, but we could never keep her healthy enough to get her to the point of a surgery. Finally, on one of her admissions, after discussions with the family, we felt that it was most beneficial to the patient to have her receive a tracheostomy and be placed on a mechanical ventilator for long term. And that actually has served her very well from a respiratory standpoint. She was able to receive a baclofen test dose kind of prior to many of her admissions for her respiratory failure, and actually had excellent results with it as far as her spasticity went. Once we had her in a decent place from her respiratory status, we re-engaged the neurosurgery service for a baclofen pump placement, and that was ultimately placed in February of this year, sorry. And then relatively quickly, once we placed her baclofen pump, she was able to be weaned off of her enteral baclofen as the intrathecal dose was subsequently up titrated. Within days of placement, she was able to come off of the dantrolene, and we had weaned the Valium dose by about 15%. And as of September of this year, she's been completely off of dantrolene. She remains on a little bit of clonidine and propranolol, as well as some weaning Neurontin. Her exam is she is much more responsive to her environment. She smiles, blinks her eyes in response to yes/no questions. She has stayed on her home vent, and I think the thing that we're most proud of is she's not been admitted to our hospital since March of this year, and all of her care has been managed completely at the home since. So her discharge medications, like we said earlier, was she's still on the amantadine and still on the bromocriptine, the clonidine patches, and the weaning Neurontin. Yes, before we move on to Catherine's portion to talk about medications, is there any questions out there about these cases? Again, these are cases kind of exemplifying two different institutions' initial managements of patients with PH, and kind of giving some example to how varied the management can be, especially given that we don't have a lot of great data or a lot of great consensus.
Kevin?
Yes.
Do either of those cases had any pre-injury symptoms that would go along with, autonomic dysfunction? Were they kids with recurrent abdominal pain or headaches or lightheadedness kind of symptoms before their traumatic injuries?
Not to my knowledge. The first patient I know was completely neurologically normal before his accident. The second, she again was at a different institution, but it is my understanding that she was also completely neurologically normal before her accident.
Thanks.
Okay, if there are no further questions, we'll move on to Dr. Schuster talking about kind of the interprofessional collaborative management and the medication management of these patients.
Good morning. Can you guys all hear me? Sorry, I'm in my office, so I'm not with Dr. Haviland and Emily.
Yes.
So I'm super excited to be here to talk with you guys because I always love how we can demonstrate how well we all work together for the betterment of our patients and to really decrease hospitalization, length of stay, and improve outcomes across the board. And one of my favorite things is that both of these patients that were mentioned, and lots of other patients, we continue to follow. And so myself and obviously Dr. McClanahan are always available to provide updates. And it's just always so rewarding to talk about how these diagnostic and treatment challenges, how they're doing, and the success stories of all the things that we've done together and the improvement. So I love sharing that. So if anyone has somebody that they want to hear an update on, I'm always happy to share. And our one young patient who is at home in the Innocents, she particularly, from my standpoint, posed a very significant diagnostic challenge because while we didn't talk about it because it's not particularly germane to PSH, she also had a spinal cord injury, which can also impact your autonomic nervous system, making it very difficult at times to figure out what symptom was coming from what injury. In the end, I think for her, it's really been her brain injury that has been the most problematic, and not necessarily her spinal cord injury, which is an incomplete injury that we are not really well able to characterize. She is also off the bromocriptine, and just as a fun aside, if you ask her questions like, are you pretty? She'll blink yes. But if you ask her something that she doesn't care about, she just looks at you with a side eye, and it's amazing. And it's one of the things I love the most about my job. So that's that being said, thank you. So why involve PM&R? So we use a lot of these medications all the time for lots of different reasons, not just for PSH. And so we have a lot of familiarity with the different medication options that can help with the spasticity that develops, the vital sign instability that develops, the central fevers. And then because we are generally following these patients for the entirety of their life, on the pediatric side until they turn 18 or 21, but my adult partners then take over. We are looking at it from a different perspective. And so thinking about how are these medications going to impact long-term outcomes, and also how will continued symptom burden impact long-term outcomes. And that's something that has been very challenging for our first case example, because you always, obviously want to incorporate the wishes of the family, but when they are doing and researching options that don't have a lot of scientific literature, it's hard to have a productive conversation at times. And so this particular family is wonderful, but just it's a good educational opportunity for us to hear their experiences with these alternative treatments, and then thinking about how you can incorporate those things in the future for your patients, because what's of value to the family needs to be included in your treatment option when you're dealing with these long-term and chronic conditions. I will say for our first example, when they brought up hyperbaric, Dr. McClanahan and I had to go look at articles about the safety and feasibility of hyperbaric oxygen on a vented patient. Like, what will a hyperbaric chamber do to your vent tubing? And there are some actual articles that talk about that. So PM&R, in case any of you guys need a refresher, our whole goal in our medical approach is function and quality of life. So what can we do to promote your function and improve your quality of life? And we know that PSH lengthens acute care hospitalizations, and it leads to worse outcomes from a rehab standpoint. And so getting a handle on those things is going to be really important, both from a hospital standpoint, but also from the outcomes and what do you want to accomplish in your lifetime for this patient. So next slide. Thanks. So treatment strategies, I think, has been very well touched on. It's incredibly multifactorial. There's limited definitive evidence, and I'm going to go through here shortly in my next slides, the medications and the ones that actually have some evidence and the ones that we use that don't have a lot of great evidence, but anecdotally are going to make a difference in that particular situation. But the primary thing that you want to do is, and one of the things that struck me looking at that algorithm that Emily put up is that one of the boxes is basically a question like, is this symptom necessary to be treated? Because you have to think about the side effects and the possible consequences of your treatment as well as the ongoing symptom. And I think that that's something really important to keep in mind. Are you causing more problems by adding a medication with side effects or an intolerable side effect burden because you're combining a bunch of medicines? And that's an individualized discussion for each patient. And one of the things that I love about working with everyone over at Norton Children's is because those conversations just are to the betterment of the patient. So ultimately what we want to do for PSH is to mitigate the excessive sympathetic outflow with medications and non-medication options, which I'm not going to touch on those non-medication options, but they include, decreased stimulation, turn the lights off, limit the visitors, repositioning, those kinds of things, which are very important to make, often in conjunction with medication utilization. Next slide. So in looking at potential risk factors to try and identify patients that may or may not be of risk to develop PSH, there are a couple of studies that I came across. And the first one is a retrospective review of adult patients. And so this, I think, went down to 17, which is not necessarily our entire patient population. But what they found in their retrospective review is that younger patients with a trach or patients with hydrocephalus were independently at increased risk to develop PSH, regardless of the mechanism of injury or anything else that had happened to them. And then looking specifically at pediatric patients, younger age, which was very surprising to me. I tend to think that younger, young 2 and younger, but that was not in the paper. That's just kind of in my mindset, have a little bit better outcomes. But in this particular paper, younger patients, male gender, and then having diffuse axonal injury or injury into the brainstem as risk factors for development of PSH. And so those are things that you can think about even as someone is in the trauma bay. Maybe not thinking about it in the trauma bay, but once they're stabilized and up in the ICU, thinking about, okay, these patients meet some of those criteria for increased risk to develop, and so we need to keep an even closer watch on them. Okay, next slide. So in terms of medication options, there was a recent incredibly well done meta-analysis that they found 48 different drugs and 22 different drug classes had been tried for the management of PSH. And I think that that really speaks to the diagnostic confusion, the importance of using appropriate terminology, and then early identification, because it can, as Emily said, be confused with medication withdrawal or an infection, and so being aware of all of the things that can happen, but also keeping this in the back of your mind, especially in those incredibly severe brain injuries. So in terms of the things that they found 6 medications that were demonstrated to have benefit, which was morphine, propranolol, clonidine, baclofen, diazepam, and gabapentin. And I'm going to go through some of these in the next couple of slides, but the thing that I'm always thinking about too is, okay, so we're controlling their PSH symptoms, but all of these sedative medications can have implications for neurorecovery, and so how to balance those things. And then the other thing is we want them to start being awake, alert, and interactive once they're not critically ill, but how do you balance trying to activate them but keeping their PSH symptoms under control, because by being more awake, alert, and interactive could trigger PSH because that would be perceived as a noxious stimuli. So a lot of times we kind of feel like we're stuck between a rock and a hard place, and how best to address what is the most pressing problem, but with an eye for the future and how this is going to impact our patients, not just while they're in the ICU, but as they move on in their rehab journey and eventually to home. Next slide. So beta blockers, and one thing that I wanted to mention before I go through all of this is the treatment of PSH is very, very regional. So I think we saw that with the case studies looking at 2 patients who both had PSH, one initially and primarily treated in this institution and one who came from a separate institution. And all of the medications that were used at the other institution are listed and known medications that treat PSH, but they are not always the same thought process that we use here. And then in my fellowship, it was also different. And I know Dr. McClanahan has said that too. So it's just fascinating how the regional differences in approach to the same problem can be. So then moving into specific medications, beta blockers, so propranolol, one of the primary ones that we use, it crosses the blood-brain barrier and attenuates the sympathetic drive. So it's going to treat your hypertension and your tachycardia, as well as a little bit of the central fever, which are probably 2 of the primary symptoms that we see, at least initially in PSH. Then moving to benzodiazepines, which are another medication that have been shown in the literature to have benefit as a GABA-A agonist with widespread neural depression, but then that leads you to the side effect of CNS and respiratory depression. And so if you're trying to wean a ventilator, if you're trying to activate them to wake them up to see what their true neuroexam looks like, you have to weigh those things together. Next slide. Opiates, another one. So morphine is the one that they primarily looked at, but we use all different variations of opioid analgesics, treating tachycardia, hypertension, and pain, which pain can be kind of overlooked because we don't know how these children who are critically ill with severe brain injuries are interpreting pain. And so can be helpful in that sense because the pain that we are unable to see or unable to diagnose is causing a noxious stimuli that is worsening their symptoms. But morphine also has the side effect of CNS depression, which can again confound neurological recovery and make it challenging again when you want them to wake up and see how their neurological exam is ultimately going to look or those early stages of recovery. Clonidine is another very commonly used medication, an alpha-2 agonist decreasing the sympathetic outflow and an agonist for the cardiovascular inhibitory neurons to treat hypertension. It can also be sedating. Clonidine has less benefit for heart rate, which is why you see us a lot of times alternating clonidine and propranolol because propranolol has a better benefit for heart rate and clonidine, I think, has a better benefit for hypertension. Next slide. So baclofen, GABA-B agonist acting at the level of the spinal cord to reduce excitatory input. The benefit of baclofen is it can be given both enteral and intrathecal. And I think a lot of you here know how I feel about baclofen pumps and intrathecal baclofen as an excellent medication and treatment option for patients of a multitude of issues. But in this specific instance, treating pain, treating the clonus, treating the rigidity, that posturing that you can see. And there are, on the adult side, a lot of case studies of use of intrathecal baclofen for refractory PSH. And that can be done, in those studies, it was described as a lumbar puncture and infusion of the intrathecal baclofen to then calm down those GABA agonists and improve the symptom burden. Gabapentin, an alpha-2 agonist for voltage-gated calcium channels, at least to the best of our knowledge, which can treat pain. It is generally less sedating and has and isn't going to have some of that neurosuppressive effect that some of the other medications that specifically treat pain can have, which can be very beneficial. Next slide. Bromocriptine. So bromocriptine is it's a very old medication. It's one of those that has limited evidence. It's a centrally acting dopamine agonist that can treat dystonia, fever, and posturing. Generally, I reserve the recommendation or utilization of bromocriptine for central fevers, which is probably the hardest PSH symptom to treat, because anytime there's a fever in these critically ill children, you're going to start thinking about an infectious etiology. And so that a diagnosis of exclusion becomes very important in this setting. And so I think fever is just a challenging symptom to manage. Bromocriptine itself can be hard to dose and titrate. And our second patient, she is off her bromocriptine and has not had any issues with central fevers. So that's exciting news for her PSH symptom burden. Dantrolene, another medication that has limited evidence, but it works peripherally, which can be beneficial when you're trying to avoid those centrally mediated agents that can cause sedation and neural suppression. But dantrolene treats rigidity and posturing. It can be hepatotoxic, and so especially as you're ramping up the dosing of dantrolene, really need to keep an eye on that liver function. And in the setting of significant trauma, you might already have hepatic dysfunction due to all the other comorbidities that happened leading up to the injury. Next slide. Again, with limited evidence, Tylenol, a prostaglandin inhibitor to treat pain and fever, can also be hepatotoxic. And so when you're adding those medications, it can be a cumulative effect. And then also thinking about central fever as a specific diagnosis of exclusion. If you're using scheduled Tylenol, scheduled acetaminophen, then you run the risk of masking a true fever, and especially in the setting of a brewing infection, which these children are all at risk for. And then dextrometamine, actually, I really have no idea how to say that the right way, because I don't think I've ever said it in its full word. So I'm so sorry, you guys. But there's a study looking at Dex and children with PSH symptoms, and those who did and didn't, they were randomized. Those who did receive Dex had a better outcome and less PSH symptoms, and a shorter hospitalization. But side effects for this is low blood pressure, bradycardia, and then CNS and respiratory depression. But as that study was kind of alluding to, is this protective against PSH development? And so that's something I think that needs to be thought about as we're using specific medications to help keep these children safe and protected in the early stages of their injury. Is this just a good medication to use in every situation? I will certainly defer that to my PICU colleagues, as evidenced by the fact that I don't even really know how to pronounce it the right way. So when I'm done talking, Dr. Havlin, will you say it for me the right way? Next slide. Thank you. I'm going to practice. Okay, next one, guys. So I think it's been very clear, as we've all been talking, is that the open dialogue and using appropriate terms is incredibly necessary in this situation, so that we can all really be on the same page and have an idea of what all of us are thinking, because these children don't have PSH in isolation. They all, they're in the ICU with a significant brain injury for, a reason, and what else is going on. And so how can we all work together? And I don't just mean PM&R and PICU. I mean everyone who's involved in these, in the care of these patients, so that we are talking about our thoughts and, if this, then this, and what if this kind of situation, so that we can improve the outcomes and decrease the length of stay. Next slide. So,
okay, and so go ahead.
Go ahead.
So, as with anything, there are definitely barriers. We've talked about several of these already, but specifically with PSH, there are multiple labels for this one diagnosis that, as you've heard, leads to confusion and potentially poor communication and delayed diagnosis as well. Again, the pathophysiology is not fully understood. And interestingly, we've spent all this time trying to shift your labeling of this diagnosis to PSH. But when you go to actually bill, there is not currently an ICD-10 code that talks about PSH. It's just not an option. So you must choose dysautonomia to bill for this diagnosis. So obviously that prevents or causes additional barriers to adopting the same terminology. So this slide, again, collaboration is key. I feel like we put this together, and I feel like we could actually probably have multiple circles all overlapping, because really, as we've all mentioned, this diagnosis kind of transcends really many of our fields, and it really takes all of us working together, using the same terminology, and understanding different pathways in providing excellent care for these patients. And so our references are here, and then we thought we would just open this up for discussion. If anybody has any questions, comments.
Well, I will certainly chime in. As I've put in the chat, the early mechanisms that y'all described so nicely are very similar to the dysautonomic features we see in patients with fibromyalgia, with that responsiveness of the anterior cingulate to increased awareness of amplification of noxious stimuli. And so many of these patients who are diagnosed with fibromyalgia also have problems with their autonomic nervous system with regards to being diagnosed with, orthostatic lightheadedness, POTS, or orthostatic hypotension. They also have other features of the autonomic nervous system being dysfunctional with regards to their GI manifestations, headache manifestations. And then there's these other overlap with patients that we see with CRPS that used to be called reflex sympathetic dystrophy, which, rather than minimizing stimulus, most therapies for CRPS from a physical mechanism ends up being increasing sympathetic stimulation or skin sensitivity stimulation to, again, try to affect the autonomic nervous system. One thing that we see of increased frequency with our fibromyalgia patients is that they are hypermobile or have increased laxity. I wonder if there's some difference in how the physical presence of either spasticity or being very lax changes the constant stimulus to the autonomic nervous system to have to adjust, and if there's some overlap there that makes both ends of this sympathetic nervous system not responding as we'd like it to, sharing mechanisms. I also wonder, has anybody, rather than using gabapentin, tried to narrow focus with pregabalin for these patients that may at least minimize some of the unpleasant side effects it could be possible with gabapentin, because we end up using both.
I have not used pregabalin. I have not seen any of our patients that have similar diagnoses use it, but I think your points, go back to kind of the two physiologic theories behind this, and I lean more towards that excitatory inhibitory ratio, especially when you're talking about the issues with tone. With our second case, I mean, it was a drastic improvement in her PSA symptoms once we got her tone under control. And so I think that the stimulus that she was getting going back to her control centers with being increased in tone was really being misinterpreted, and that was kind of leading to that sympathetic overdrive. And so really, once we got that under control, we really saw a significant improvement in all of her other PSH symptoms, and I think that's evidenced by the fact that we were able to wean off of a lot of the medication that she was on. So I agree that there's something there with that balance between the excitatory stimulus and the inhibitory signal, that maybe it is evidenced by the mention of the laxity versus the increased tone. But I have not seen anybody use pregabalin. I don't know if Catherine has used it before.
We use it more in the outpatient setting for pain-related things, so CRPS and kind of chronic pain symptoms, rather than for PSH, because one of the other things that we have to think about too is the availability of these medications. Like, how can we deliver them to the patients in terms of the formulations? And pregabalin does come in a liquid. That's not an easily obtained liquid. So in an acute ICU setting where, you know, we have a G tube, an NG tube, we need something that we can easily dose, which can make some of these medications hard to get to the patient effectively due to the limitations. But definitely pregabalin in an outpatient setting, but much more along the chronic pain side, not so much the PSH. But and I don't know, and I've not had anyone that had such refractory storming that I feel that the gabapentin was like the one that really made the most difference that would cause me to want to switch to pregabalin. Like, if this could just work a little bit better. But that's an interesting thought just in terms of refractory PSH. I almost said storming, look at me. Refractory PSH, that would be something to think about. But I think that our cases that we have presented as refractory, we have ultimately been able to come up with something that is of most benefit. And I would say our second case, we were considering refractory, and her baclofen pump really fixed her refractory PSH.
We have another comment in the chat from Dr. Furlong-Dillard asking about the age that we would use the algorithm for. So you really can use it for any age because the second PSH AM tool that was developed with Pediatrics in mind shows age ranges, and I was going to say I could probably go back and pull it back up, but the pediatric based scoring gives you. Sorry, we're going to scroll back quickly. Hopefully it doesn't make you sick. So go back to the one more slide. There we go. Actually, hold on. We went one too far. There we go. Okay. So see here by the for the pediatric scale, which you can see on the screen, they list the age of the patient and try to capture better vital sign norms to answer your question with this pediatric scoring range. And then you add, if it's a pediatric patient, you would add this PSH score with the DLT or diagnostic likelihood score to then get your total score here at the end. And those patients would still fall into this category of less than 8 points, 8 to 16 points, or greater than 17 points. And then I'm going to use the little laser here if I can. And you see those point systems come into play here. So you're either using in this stage or in this step prior to that to attaining your points, you're either using an adult or a pediatric tool to hopefully capture those children a little bit more realistically. Hopefully that answers the question. And then go back to let's see. Oh, not a problem. Okay, and then we have another comment in the chat from Dr. Mulser. Is PSH approached or treated differently in patients with more chronic progressive brain conditions as opposed to an acute traumatic brain injury?
That might actually be a better question for Catherine, since she sees most of these patients as an outpatient. And most of what we see in the ICU is the acute brain injury patients. Catherine, do you guys kind of approach it differently with progressive brain conditions?
So that's a super interesting point. And I can't say, just thinking off the top of my head, that we've had someone that has a progressive type condition that goes on to develop what we would call PSH. That just neural degeneration symptom constellation is really going to be dependent on the underlying etiology of that progressive underlying pathology. But I think the medication options and the medication treatment would fall under the same thought process in terms of what is the most predominant symptom and what are you trying to accomplish with your medication and what side effects are acceptable or not in the setting of a progressive chronic condition. Because then you're also thinking about, all of the other things that go into the management of a chronic progressive pathology, which is going to be a different thought process from a management palliative type situation, if I'm interpreting your question correctly.
Right. I think it comes down to kind of symptom management at that point. There really isn't a lot. We mentioned the dexmedetomidine being potentially protective. I think ideally, if we could figure out something that on the front end could be a protective thing, then we could focus more on prevention. But ultimately, the management of PSH comes down to management of symptoms and management of tolerance of the medications that are controlling those symptoms. And so I would think that if a patient with a chronic progressive neurologic injury is exhibiting these symptoms, the management strategy would be pretty similar, figuring out which symptoms are a problem and how to manage them without undesired side effects to the family.
Thanks, guys. This is Sarah Moulter again. I have another question. It was just going to take me too long to type. Can you hear me okay?
Yes.
So another question I had as I was listening to you, you mentioned the idea that this is often a diagnosis of exclusion, especially when fever is involved, and that these patients often are, at risk for infections, thrombosis, et cetera. And we often end up doing a pretty big workup looking for all those other things when they have episodes of PSH. Do you have any guidance or suggestions about when we might be able to forego those large workups looking for other things and just say, this is PSH? Does it come down to maybe the tool that Emily referenced, or are we stuck doing that workup every time?
We're in here laughing because we looked at each other as soon as you said it. Most of these patients wind up getting several kind of full septic evaluations, courses of broad spectrum antibiotic coverage, mostly because, again, in the acute phase, we are, these patients have invasive support devices and monitoring devices, and so their risk for infection is incredibly high. And so early on, we are not comfortable foregoing that infectious workup. Usually, from our side, it takes a few of those workups, probably involvement of infectious disease and neurology plus minus PM&R, before we really say, okay, this is semi-infectious. I do think the algorithm can help, but especially in the early stage, I would be hesitant to forego infectious workup in a patient who's probably still on the ventilator, has central access, things like that.
And again, I think, while we have to still look into all those different avenues, I think just having this out there as an early discussion point, even getting it on the differential diagnosis, is important, because it can, guide our conversation. So, if your other pathways don't end up showing you, that there is infection or whatnot, at least we've already been talking about this and looking towards next steps to help streamline that care again.
And I think the other thing about this is PSH generally occurs within 9 to 14 days of injury. And so looking at the timeline of what the injury was and then when the symptoms develop, because I would be less inclined to think it's PSH if someone has been, stable from their chronic brain injury standpoint. Well, not chronic, but, they've been in the hospital for a month, they've been stable with their symptom burden, and all of a sudden this came up. So that's something else to think about in terms of, is it PSH or is it something else? What their overall just kind of presentation has been thus far, also I think is going to play a big role.
Well, it's 9 o'clock, and if there aren't any further questions, thank you guys for attending. Hope you enjoyed our talk.